Good morning to everyone. Okay, so very warm welcome to the PYQ discussion on microbiology. Okay, so it shows very good enthusiasm for the morning. 6 a.m. we are joining here. Okay, for discussing microbiology. Okay, so in 1 hour we'll cover the most of the important topic in microbiology. It will be taken as a revision as well as it will be cumulative of a previous year question. So this is not taking the same question. So we will cumulate the multiple questions. For example, the question is asked from the sterilization part. We will combine all the question in a single. Okay, that's why we can able to discuss. So all the question will be in a single stretch. Okay, so with that, okay, so we'll congratulate for your exams. Okay, do well and with the confident. Okay, so we'll move on to the session. Yes. Okay, first we'll take about the media. The wrong statement regarding the culture media in microbiology. So any question from the culture media, always we have to just differentiate what about the type of media it is belongs to. Okay, so any media questions you are getting in the exams, the two things to have to done first, the classification number one. Number two, this media for which organism. Okay, so broadly we can classify it into gram positive or gram negative, or belongs to in which category. In gram positive means it is for the cocci or it is for the bacilli. Similarly, in gram negative means it is for enteric bacterium or a non-enteric bacterium. Okay, so let's have the options here. Blood agar is the best for anaerobic organism. Chocolate agar is best for hemophilic organism. Jensen medium is best for mycobacterium. And McConkey agar is best for 10% to 10% sheep RBCs are used for agar. Here, RBC membrane is not intact. We are exposing the RBC membrane to the temperature by which we can make the rupture of RBC membrane. Start again. Yes, so blood agar, the RBC membrane is intact. In chocolate agar, the RBC membrane is ruptured, and let all the content of the RBC will be moved and are present in the medium freely in a chocolate agar. The bacteria has to break the membrane of RBC membrane, then only it will take the nutrition from the blood agar. Okay, so just let it have a common point to remember. Blood agar will be usually taken for a specific medium, not selective, is a specific medium for gram-positive organisms, because gram-positive organisms are capable of breaking the RBC membrane by releasing the toxin we called as hemolysin. We have alpha hemolysin, we have beta hemolysin, and it have very effective hemolysin from gram-positive bacterium. But coming into a chocolate agar is more specific for a gram-negative organism, because the gram-negative organisms doesn't have the effective hemolysin property. Most of the bacterium, not all, most of the bacterium, so it will doesn't able to break the membrane. So that's why we are breaking the membrane. Then let all the RBC content will be present here. We can consider as it is specific for gram-negative organism. So this will be one of the important point. Remember, blood agar will be specific for gram-positive. Chocolate agar will be specific for a gram-negative organism. Then coming to the McConkey agar, okay, by classification, it is comes under a differential medium. Okay, what is the meaning of differential? Yes, what is the meaning of differential? Yes, it will differentiate the bacterium into two categories. Depends on one classical property in the medium is lactose utilization. If the bacteria will be utilizing the lactose, we call it as lactose fermenting bacterium. If the bacteria is not taking the lactose, we call it as lactose non-fermenting bacterium. Based on, we can differentiate, especially the enteric microbial agent in a gram-negative category, differentiate into lactose positive and lactose negative. Then coming to the Lowenstein Jensen medium, it is specific for mycobacterial category or mycobacterial group. It is not only for Mycobacterium tuberculosis and also for other atypical Mycobacterium like Ansasi, bovis, or fortuitum. So all the Mycobacterium except Mycobacterium leprae will grow in LJ medium. Then coming to this medium, you can see it will be completely screw capped, and there will be something will be there oxygen for their growth. It will be disturbing the bacterial growth by exposure of oxygen. So we are completely blocking the oxygen entry by a screw cap container, as well as we can seal the glycerol or liquid paraffin in the surface of the liquid medium. Okay, so here we are using the word broth. So broth means it is a liquid medium and it contains meat particle as a source of nutrition. Okay, yes. So let's go for the question. Wrong statement regarding the culture media in microbiology. Blood agar is best for anaerobic organism. No, anaerobic organisms are grown in a medium called as Robertson meat particle broth. Yes. Chocolate agar is best for, yes, hemophilic organism. Yes, what is the meaning of hemophilic? It is called as a blood-loving bacterium. So we are putting chocolate agar. Hemophilic organisms are gram-negative. So gram-negative organism, chocolate agar will be the best. Then Lowenstein-Jensen medium is best for mycobacteria, which include both MTB as well as atypical mycobacterium. And McConkey agar is used for differentiating gram-negative enteric pathogen into lactose positive and lactose negative to remember. So now what about the wrong statement? That's called as incorrect statement. Blood agar will be suitable for gram-positive bacterium. Based on blood agar, we can classify the gram-positive into alpha hemolysis partially, beta hemolysis complete, and non-hemolytic. Okay, that is the main purpose of blood agar. So blood agar is prepared by using 5% sheep blood, okay, not using the human blood. There will be one standard question why the human blood is not using, because the human blood which contain lot of microbial inhibitors, because blood will be a sterile fluid in human body. Within the vasculature, it contain lot of microbicidal agents will be diffused in the blood that will be blocking the growth of bacterial agent. So that's why we are preferring a sheep blood. Sometimes we are using the horse blood or the goose blood, okay, for different microbial agent to grow, but universally we are accepting the sheep blood will be most favor for the bacterial growth, which doesn't have any inhibitor to remember. Okay, yes. Now coming to the next question. Ritter's disease is a superficial manifestation affecting the children is caused by which microbial agent? Yes, Ritter's disease. Yes, there is a one clue we are getting from the option, because all the four are bacterial agent. So we have to think it is a bacterial disease in children. Okay, yes. So now, very important point, remember, if we are taking the clue will be the children. So children will be affected by Streptococcus, pneumoniae, Pseudomonas, and it is a bacterial manifestation or is a toxic manifestation, ma? Ritter's disease, it is a toxic manifestation of Staph aureus. So what is the toxin is involved here? It is, yes, very good. The toxin will be epidermolytic toxin or exfoliative toxin. Exfoliative toxin of Staph aureus. Organism will be colonizes first in the skin. After the colonization, it releases the toxin. The toxin will be responsible for the manifestation we called as exfoliative or epidermolytic toxin. Okay, there will be two different manifestations are possible by the exfoliative toxin. A mild manifestation in children will be called as a bullous form, we called as a bullous impetigo, and severe form will be called as staphylococcal scalded skin syndrome. It is nothing but Ritter's disease. Okay, if the same manifestation will be happening in adult, we call it as toxic epidermal necrolysis. So what is the one important point to remember here? Scalded skin syndrome is manifestation in children under the age of 10 or 15, and 10 will be the manifestation in adult. Both are severe form, okay, leads to a blister formation. Okay, sometimes this blister formation can be confused with some of the other exfoliative diseases like the gangrenous wound by Clostridium perfringens or by Bacillus anthracis, sometimes due to the heat exposure, sometimes due to the drug toxicity, drug adverse reaction, especially antipsychotic drugs we called as neuroleptic malignant syndrome. So we can able to differentiate this exfoliation is specifically due to Staphylococcal, not by the other forms. We can able to differentiate by the sign called as Nikolsky sign. If we are giving the gentle pressure over the skin, slowly the skin will be producing the blister or the bullae and it will be slough off. If you are giving a gentle pressure for 30 seconds to 1 minute, that is called as a Nikolsky sign. Then in the case of the Clostridium and Bacillus, there will be a mild painful lesion we call as malignant pustule or the gangrenous wound that will be a slightly painful, but here it is painless. So painless, a skin lesion, exfoliation in children will be considered as a Ritter's disease or staphylococcal scalded skin syndrome. Okay, so we have to treat the condition by either clindamycin or erythromycin. The gram-positive spectrum will be useful. Once we are blocking the bacterium, doesn't require any other extra treatment, though it is due to the toxic manifestation, doesn't require antitoxin. Because bacterium and toxin both will be in the same localized area. If you are blocking the bacterium, automatically the toxin production can minimized. Okay, so the Ritter's disease is the manifestation of Staph aureus. It is a toxic manifestation of Staph. The habit of contact to the water. Yes, the water contact of Pseudomonas aeruginosa. Yes, it is called as a swimmer's ear or malignant otitis externum. The exposure of the water in the external artery canal will make the infection we called as swimmer's ear or malignant otitis externum. Then coming to the Streptococcus pneumoniae, it is responsible for pneumonia as well as meningitis in children. Moreover, Streptococcus pneumoniae, otherwise called as pneumococci, is responsible for sinus and otitis media, sinusitis infection in children. There is a one more gram-negative bacterium will be responsible for the same manifestation like otitis media, sinusitis, pneumonia, and meningitis is Haemophilus influenza. So we have to differentiate Haemophilus influenza from Streptococcus pneumoniae by gram stain, as well as we can able to differentiate by the media. So H influenza is a non-hemolytic and Streptococcus pneumoniae will be alpha hemolytic bacterium. Moreover, if we are starting the treatment, Streptococcus pneumoniae will be response to cephalosporins and H influenza also will be respond to cephalosporins, okay, effectively. Okay, and coming to the prevention, both the conditions can be prevented by a capsular vaccine we call as a subunit vaccine. Okay, then what is the one uniform feature for capsular vaccine? H influenza and pneumococci is having a capsular vaccine. It will block only the systemic manifestation, not the localized manifestation. Moreover, Streptococcus pneumoniae vaccine is a multivalent or polysaccharide vaccine. But H influenza, we are taking only one serotype, that is monovalent, especially the capsular serotype B will be taken for preparing the vaccine. So H influenza is a monovalent vaccine. Pneumococci will be a multivalent vaccine. Okay, right. Now coming to the next question. The stained smear was prepared from the throat. An individual match the staining procedure and organism from the list. Okay, so here we are getting the organism, okay, in a green color, and there will be a polar bodies. That polar bodies will be considered as granule. So the granule is important for growth of the microbial agent because the bacteria doesn't have mitochondria for the nutritive purpose. So to replace the mitochondrial function, bacteria is having the granules to store the nutrition or the energy. There is a multiple granules are there in the bacterium. It is a polysaccharide granule, or it is a glycogen granule, or the starch granule. Okay, so in Corynebacterium, the granules are showing the property called as metachromasia. What do you mean by metachromasia? We are providing the one color, the organism that's granule will express a different color we called as metachromatic. So it is called as metachromatic granule, or we called as volatile granule, or it is called as a phosphate granule. It is a diagnostic of Corynebacterium diphtheria. Then what about the clinical manifestation? It forms a pseudo membrane over the throat. What is the reason for pseudo membrane? Yes, the bacterium is replicating in the throat. It will damage the pharyngeal epithelial cells. The dead cells will be deposited in the pharyngeal epithelium, okay, which will mimic a membrane. Okay, it is a pseudo membrane because it is not a viable cell, it is a dead cells. Okay, then what about the systemic manifestation is due to diphtheria toxin? Yes, what about one important point remembered for diphtheria toxin? The toxic production is depends on the two factors. Number one is POG. Number two is iron content. The two factors will decide the toxic production. So the low iron content will facilitate the toxic production, and the POG mediated mechanism will be taken for the toxin production. That is called as a beta POG. It is a lysogenic POG. The bacterium is called as lysogenic bacterium. So the POG mediated toxin production will be very classical example from Corynebacterium diphtheria. Okay, the iron content also. So the iron content will have a dual edge. For example, the lower concentration of iron will favor the toxin production, that is 0.1 milligram per liter. If you are increasing the iron content to 0.5 or more than this, it is paradoxically inhibit the toxin production. So this is very well used in the case of the media preparation. If the media will contain the very low level of iron, that favor the toxin production, because we have to demonstrate the toxin after the growth of bacterium in the Lowenstein, the Loeffler's serum slope by using the method called as LX gel precipitation test. So LX gel will be used for demonstrating the toxin, one method. The second method, we can able to demonstrate, yes, the toxin gene by polymerase chain reaction. Okay, so bacterial isolation by using the media. What is the two media will be used? Loeffler's serum slope and potassium telluride agar will be used. The toxin, okay, so the bipolar staining is nothing but the pattern. Okay, the safety pin appearance or safety pin pattern. So we are doing a Weissen stain for demonstrating this bipolar staining, demonstrating the Haemophilus ducreyi, Pseudomallei, Vibrio parahemolyticus, or Burkholderia. These are all the organisms, Yersinia pestis. These are all the classical organisms for their safety pin appearance. That is called as a Weissen staining. Okay, yes. So diphtheria will be demonstrated by Albertson for metachromatic granules. Okay. The efficacy of treatment in syphilis can be monitored by, yes, syphilis treatment. The efficacy of treatment is monitored by, yes, specific test or non-specific test. So the non-specific test will be used for a treatment monitoring. It is otherwise called as standard test for syphilis. Okay. So why the VDR will be taking the concern for a standard test? It is called as a non-specific. We are using a cardiolipin antigen, otherwise called as a Calcutta antigen, because it is prepared in the Calcutta. Okay, that is called as VDRL antigen. So VDRL will be a primary test. We are slightly modifying the VDRL from the microscopy to the macroscopy. We called as RPR. So RPR is a macroscopic test. VDRL will be a microscopic test. There is more sensitive with the VDRL because it requires the inactivation of serum as well as it requires microscope. That's why we are slightly switch over to the RPR. It is a macroscopic test. It's a rapid COT test. We can done the procedure maximum in 5 to 10 minutes. So for the easy procedure, we are offering RPR, but the more sensitive will be VDRL. We are using Calcutta antigen or a cardiolipin antigen. Okay, right. So once we prepare the antigen, we have to use within 6 hours. The antigen will be highly unstable, so we cannot store the antigen once prepared. Similarly, if we are taking the serum from the infected individual for the testing of syphilitic antibodies, the serum has to be inactivated by 56 degrees centigrade for 30 minutes to inactivate the complement proteins. test. So after the inactivation, the serum has to be tested within again 6 hours because the proteins are only inactivated. The proteins are not destroyed, not denatured. The inactivated protein may react 6 hours. So the inactivation of serum is required for performing the VDRL test. So this is a cardiolipin antigen, otherwise called as a Calcutta antigen. The one important point, remember, in secondary syphilis, all our serological tests will give 100% positivity because the bacterial load is very high. But in coming into the primary syphilis, the non-specific test will be giving 70 to 80% sensitivity, and we can able to demonstrate the organism from the lesion itself by dark field microscopy. What about the motility will be exhibited in dark field microscopy by treponema? Yes, it is called as corkscrew motility because of endoflagella or bidirectional movement of endoflagellum, we have a corkscrew motility. Because of very thin organism, we have to put something on the surface we call as silver impregnation to demonstrate the bacteria in the form of dark field microscopy. Here we are using the reflection mechanism instead of transmission mechanism in other microscope. Coming to the tertiary syphilis, again the non-specific test will be less important compared to the specific test. So tertiary syphilis, we can offer specific serological test. In primary syphilis, we are offer non-specific serological test. In secondary syphilis, we can do any test. It will give positivity. So why the VDR will be considered as a treatment effectiveness or a standard test for syphilis? Very simple. Number one, yes, for the screening purpose, we are performing VDR. So screening will be done in two places. Number one, yes, from the blood bag, we are screening. Number two, in the antenatal period, we are screening. So two screening areas, we are performing only the VDRL test. Number two, we can able to assess the bacterial load by using VDRL. Okay, the amount of the dilutions will be directly proportionate to the bacterial load. Number three, yes, treatment effectiveness. So treatment will be effective or not, we can able to assess. Now it can be used for a follow-up. We are repeating the VDRL test after 2 weeks or 3 weeks or 2 months. The slowly the dilutions are get reduced. That can be used for follow-up. More important, we can declare the person is non-infectious depends on the dilution of VDR. That is less than or equal to 1:8. Yes, we can declare the person is non-infectious or non-dangerous to spread the disease to the other individual. Need not to wait for the negative VDR. Because of these 5 significance, the VDR will be considered as a standard test for syphilis. Moreover, the specific test may give positivity for a longer duration, maybe for 5 years or 10 years. Some non-specific or standard test for syphilis. Okay, right. Yes, find a correct match in the respect with latent infection from the herpes family. Yes, what is the meaning of a latent infection? So microbial agents are present in the tissue without have any replication, without have any disease manifestation, we called as a latent infection. So latent infection is not only for viruses, it may be present in any microbial agent. Okay, we have 2 types of latency. One is called as a true latency. Next one is called as a clinical latency. So what is the difference, ma'am? True latency means organism is present in the tissue. Yes, no replication, no symptoms. Yes, what about the clinical latency? Organism is present, clinically no symptom, but organism will replicate. Okay, that is the one difference between a true latency and a clinical latency. Yes, the classical example of clinical latency is retrovirus. So from the initial part up to the 8th stage, the virus will be replicating slowly, but the person doesn't have any symptoms. We called as a clinical latency by retrovirus, and other viruses and bacterial agent will have a true latency. Okay, so let's have the latent part. Yes, the HSV1, 2 will be present in the ganglion or neuron as a latency. So trigeminal ganglion or sacral ganglion will be the ideal choice. Then HHV5 is nothing but cytomegalovirus. He is present in the glands and the kidney as a latency. Then coming to the Epstein-Barr virus is 4 and Kaposi sarcoma will be 8. Yes, EBV and KSV, Kaposi sarcoma, primarily present in the B cells as a latency. So latent infections are very classical for the herpes group. Only based on the latency, we are classifying into a 3 family, alpha, beta and gamma. Okay, so among this, gamma family will have one unique feature. We can see EBV and KSV. From the name itself, there can be strongly linked with, yes, malignant transformation. So gamma family of herpes will be otherwise called as oncogenic family. So HSV is present in the ganglion. Epstein-Barr virus is present in the B lymphocyte. And varicella zoster will be present in the again ganglion, and cytomegalovirus will be present in the kidney. Okay, now how CMV will differ from other herpes viruses? All the herpes viruses will be responsible for the manifestation as a primary disease without connecting with the immunity. But cytomegalovirus, it is mainly concentrating on immunosuppressed individual. If the immunity is good, we are not getting any symptoms of cytomegalovirus. Okay, apart from cytomegalovirus is especially a immunosuppressed individual will be developing the disease, retinitis in case of HIV and pneumonia in the case of transplantation individual and a malignant person. So cytomegalovirus, why it's have the name of cytomegalo. Once the virus is infected, it will enlarging the size of the host cell. Then what about the inclusion body we can demonstrate in the case of cytomegalovirus? Yes, inclusion body, it called as owl's eye. Inclusion body will be demonstrated because it produces inclusion in cytoplasm as well as in nucleus. But some viruses will be producing only in cytoplasm, some will produce only in nucleus, but cytomegalovirus is the one virus which is capable of producing inclusion in both the areas. That's why it's make the owl eye pattern to be remembered. So what is the treatment for CMV? Post-transplant, yes, post-transplant will be most susceptible for CMV. If any transplantation, especially renal transplant or any solid organ transplant, the first virus to be infected individual is BK virus. The next virus will be, yes, cytomegalovirus. So any transplantation individual, we can think of 2 infection. One is BK, second one is CMV. Okay, the CMV with the good immunity, we can go for ganciclovir. If the immunity will be less, better go for first cornet, because ganciclovir will be common for all the herpes family. If the person is immunosuppressed, better go for first cornet. Okay, HIV, CMV, first cornet. Transplantation CMV, first cornet. So ganciclovir will be given if we are getting some amount of immunity in the individual. Better go for ganciclovir to be remembered. Okay, yes. The incorrect match with the presentation of DNA viruses. Yes, the incorrect match with the presentation of DNA viruses. Adenovirus, yes, conjunctivitis, it is mainly by, yes, 3, 7 for conjunctivitis, called as a follicular conjunctivitis or swimming pool conjunctivitis. Then coming to the varicella chickenpox, varicella zoster virus, it is called as a chickenpox lesion. Then parvovirus is responsible for erythema infectiosum or 5th disease. The classical presentation will be a slapped cheek pattern, because rash will be started on 4th or the 5th day in the face, especially in the cheeks, will give a slapped cheek pattern. Then coming to the papilloma virus, the 6 and 11 will be linked with only wart lesion, and 16 and 18 will be start with the wart lesion and extending into a malignancy. It is called as a oncogenic DNA viruses. Okay, now coming to the JC virus. JC virus is again coming to the family of a polyoma viruses. What is called as a polyoma? Yes, oma means malignancy, carcinoma. Okay, oma means malignancy. Poly means multiple. So the multiple oncogenic involvement will be present in this group, especially in animals, not in human. So some of the polyoma viruses are common in animals, and some will be common in human. We have two polyoma viruses. One is BK and the next one is JC virus. So JC virus will be entered through oral route in an immunosuppressed individual. It replicate in bone marrow, it replicate in renal glomeruli, and it may be excreted in the urine. If you want to demonstrate the virus, better we can go for either bone marrow biopsy or a urine sample because it is intermittently excreted. So it is not by taking a single sample, the multiple samples will give the clue for identification of the JC virus in a immunosuppressed individual, especially HIV and malignancy. So JC virus will be responsible for lesion called as progressive multifocal leukoencephalopathy. It is a highly fatal disease. So erythema infectiosum is a manifestation of parvovirus. Okay, if the parvovirus is infecting in pregnancy, what about the manifestation? Parvoviral infection in pregnancy. Yes, it is considered as Hydraps fetalis without have any involvement of antibody. We call it as non-immune Hydraps fetalis. Okay, so Hydraps fetalis is due to RH incompatibilities, comes under type 2 hypersensitivity reaction. Okay, in parvovirus, it is taken as non-immune Hydraps fetalis. We can differentiate by, yes, history. It is a first pregnancy or second pregnancy. Then we can go for the Coombs test and we can demonstrate the parvoviral antibodies in the serum. Okay, at the same time, the RBC destructive mechanism will be slightly different. Then what about the treatment for parvovirus? Yes, no specific antiviral, but we have to give immunoglobulin to minimize the replication of the virus. So what is the target mark? The target of parvovirus is erythroid cells in the bone marrow. Okay, it is one of the bone marrow target, that is parvovirus. What about one specific feature in the morphology? Parvovirus is the smallest virus. Number two, it is a single-stranded DNA virus. Okay, smallest, that is a 15 nanometer in diameter, that is a spherical morphology, and it is a single-stranded DNA. Usually DNA means double-stranded. This will be a single-stranded to be remembered. Okay, yes. In the process of antigen presentation in the APC, describe the nature of antigen. Yes, describe the nature of antigen. Yes, okay, yes. So normally, this is the first picture is called as a complete antigen. It is presenting antigen in the center groove of MHE and T cell receptor. So T cell receptor will have alpha and beta, and MHE class 2 is present in antigen presenting cell. The antigen will be presented in the center groove. But what about in the case of super antigen? The antigen is not presenting in the center, it is presenting in the variable side chain in the beta. So V beta, V for variable region, beta for side chain. So V beta side chain will be the position of the super antigen. Okay, because of the super antigen, what happened? It increases the T lymphocyte activation. So 20% activation compared to 0.2% activation during a normal antigen. So can you give the examples of super antigen? It is mainly a product from the bacteria, that is a toxin from Staph aureus. We call it as a TSST, an enterotoxin. Then Streptococcus pyogenes, again TSST, and Mycoplasma in their M proteins, and Yersinia pestis toxin. Okay, these are all the super antigen stimulus. So super antigen means we have to remember three important things. Number one, the site of attachment is slightly different. Number two, activation of the T lymphocyte will be in an excessive manner. Number three, amount of antibodies as a result of stimulation will be on the higher side. That can leads to antibody mediated cell destruction. Okay, because of antibody will be destructing the cell, it is comes under which hypersensitivity? Yes, antibody will damage the cell, cytolysis. It's called as type 2 hypersensitivity. Type 3 means antibody deposition. Antibody will deposit, that will induces inflammation is type 3. Antibody will be directly damaging the cell because of excessive antibody stimulation is a type 2 hypersensitivity. So super antigen stimulus, remember, Yeah, site of attachment, T cell involvement will be 20%, more antibody, type 2 hypersensitivity will damage the host cell, which leads to, yes, antibody damage. Antibody will damage the cell will be a type 2 hypersensitivity. What is the mechanism? It is a cytotoxic mechanism. What is the mechanism of type 3, ma? It is immune complex deposition, which leads to, yes, inflammatory process. That is a chronic, that is a longer duration. So a chronic manifestation or the chronic mechanism is type 3. Okay, that is rapid destruction mechanism will be type 1 and type 2. Type 1 is anaphylactic, type 2 will be cytotoxic mechanism to remember. Yes. So false statement regarding malaria. False statement regarding malaria. Multiple rings, chromatin will be seen in falciparum. Enlarged erythrocyte will be very classical for vivax and oval. There is one more common feature to remember. In vivax and oval will be attacking young RBCs. So young RBC and enlarged erythrocytes in vivax and oval. Then persistent exoerythrocytic cycle is absent in falciparum. What do you mean by exoerythrocytic cycle? That is a dormant stage in the liver, nothing but hypnocytes. So hypnocyte stage is absent in falciparum. Because of hypnocytes are absent, which stage is or which cycle is absent? Relapse cycle will be absent. So no relapse in falciparum. Okay. Now we are getting the two types of malaria. One is called as mosquito bite malaria, that is due to sporozoid entry. Yes, apart from the mosquito bite, we are getting the infection by blood transfusion, that is mainly due to the trophocytes. So trophocyte will be enter, we called as transfusion induced malaria. If the sporozoite is enter, we called as a mosquito borne malaria or natural malaria. So only in the case of natural malaria, all the 5 stages will be present. If the person is getting the blood transfusion induced malaria, only trophocyte and followed by gametocyte, there won't be any other stages will be present. Okay, that is the main thing. Then how we can able to diagnose? By taking the blood smear, thick smear and thin smear. The shape of the gametocytes will give the classical finding for identification. If it is a banana or sickle shape, it is Plasmodium falciparum. If it is a oval shape, we'll be thinking as vivax or oval. Okay, so most of the time, the malaria may not be detected because of it is affecting the old RBCs. Most of the time, before it get mature, it will be trapped in the spleen and going for destruction. Moreover, one important point, remember, Plasmodium malariae will be responsible for a renal manifestation in malarial disease. So, 2 Plasmodium species will be linked with renal manifestation. One is Plasmodium falciparum, blackwater fever, and yes, hematuria. And Plasmodium malaria will be responsible for tubular necrosis because of N arteries is trapped with RBC, which contain Plasmodium because of the size will be the larger because of end arteries or trapping mechanism. So infective stage of transfusion malaria is not sporozoid, it is a natural malaria. Okay, what about this malaria diagnosis in a rapid method called as SQBC? Yes, quantitative Buffy coat. It is a fluorescent technology-based diagnosis. A capillary tube will be coated with acridine orange. Take the blood sample, centrifuge. We can create multiple layer. We call it as, it depends on the density. We are concentrating on the Buffy layer for gametocytes. Because of the gametocytes are already stained with acridine orange as a fluorescent dye, we can able to demonstrate by a fluorescent microscopy. So we can quantify the amount of gametocyte. The coat will be that acridine orange, concentrating in the center layer, that is called as a Buffy layer. That's why the test is called as quantitative Buffy coat. Coated with acridine orange, Buffy layer to concentrate on gametocyte for the purpose of. Okay, so the immunochromatographic test. So the test band will be the first and followed by the control. The sample will be touching the test band and followed by the control band. The control will be always the last. So sometimes there will be mismatch and given the exam. So always the control will be the last because the sample will touches the control band at the last. Okay, yes. Now the following technique will be used to demonstrate the following parasite. This is a very simple technique to demonstrate which parasite. Yes, Enterobius vermicularis, right. Now, what are the points to be remembered for Enterobius vermicularis? Enterobius is a pinworm or threadworm. It is called as a cellophane tape method or scotch tape method. There is one more method will be available. We can demonstrate by NIH swab. It is a National Institute of Health swab that is taken as the rectal swabs to be remembered. Okay. So, someone asking about the QBC. So QBC is nothing but is a quantitative Buffy coat. Okay, we take the capillary tube. That capillary tube will be inner coated with acridine orange is a fluorescent dye in which we are collecting the blood sample. Once we centrifuge, the blood cells are separated depends on their gradient or the density. The heavy molecules are bottom, the light molecules are in the top. In between, we are demonstrating the Buffy layer. In the Buffy layer, the gametocytes are stained with acridine orange. We are focusing under fluorescent microscopy. It is one of the important method to demonstrate the gametocytes, okay, without tracing, without searching. Because of the fluorescent staining, it is easily demonstrated, and even we can able to count the number. That's why it is orange as a fluorescent dye. Okay, so NIH swab. Yes, NIH, that is a National Institute of Health swab, will be used for collecting the rectal. Then coming to the eggs of Enterobius, it will be a plano-convex eggs. Yes, infection. So Enterobius is one of the example for a auto-infection, especially in children. It is responsible for nocturnal, perianal pruritus. Okay, so nocturnal, perianal pruritus. Okay, so now clear, ma? I am repeating. It is a plano-convex egg. Inside we have a larva. It's called as a tadpole-like larva. Okay, and it is responsible for nocturnal perianal pruritus. Because it's nocturnal pruritus, the child will be scratching the perianal region. The eggs will be taken by the nail bed and going for a auto inoculation. It will be taken as a new infection without entering into the soil cycle. So this methodology will be taken for Enterobius vermicularis. Okay, now what are the parasites will be linked with the soil in the list? Yes, linked with soil. Yes, Ancylostoma duodenale and Strongyloides stercoralis. The larval stages are present in the soil. Okay, so both the larval stages are penetrating the skin. So skin penetration. Okay, larva will be penetrating the skin by which the humans are getting the disease. Okay, yes, now the spaghetti meatball appearance by Malassezia furfur, that will be very classical, right? Yes, what about the lesions? The lesions are hypopigmented lesions, no itchy, no scaly, no spreading. Moreover, it is a non-painful or non-pruritic lesion. It is only a hypopigmented lesion. So from the scrapings, we can perform a spaghetti meatball appearance in a staining or in KOH. Okay, is demonstrated. This is called as spaghetti meatball appearance. Okay, if we are using this saprose dextrose agar that is added with 1% olive oil, we can get yes fried egg pattern of the colonies, because the fungi will be a lipophilic fungi. It requires lipid for the growth. It is a fried egg colonies will be there. Okay, which condition we are getting the fried egg colonies? Which bacteria we can get the fried egg colonies? Yes, that is mycoplasma. We are getting a fried egg colonies in a bacterial culture. Then once we are exposing the lesions in the wood slab, golden yellow pigment in Staph aureus, golden yellow fluorescence in Malassezia furfur. So Malassezia furfur or Malassezia globosa will be responsible for a superficial infection that treated with topical azoles. Okay, well, mainly we can give a miconazole or topical azoles will be given as a treatment. Yes, along with we have to give the advice, make the skin dry because it is a lipophilic fungi. lipid loving fungi. So possibly we can keep the skin will be in a dry manner. That is a frequent bathing 2 to 3 times in a day. The frequent bathing may help for reducing the number of the microbial agent. Along with we can give the topical azoles. So spaghetti meatball appearance in smear and fried egg colonies in culture and golden yellow fluorescence in the Woods lamp examination with 365 nanometer of the wavelength will be taken for diagnosis. Okay. Yes. How it is differ from other superficial infection? It can be purely spreading by a direct contact. Moreover, it is present mainly in the person who have high sebaceous secretion. It is a age-related fungal infection. It is not in all individual. In children, is very rare. In older person, is again very rare. So only in the teenage people or the young adult will be responsible for getting the disease because of the high oily secretion or the sebaceous secretion will be taken here. Okay. Yes. So with that, we are just concluding the session. So thank you for your patient listening, and we'll meet you in one more session to revise before your exams. Thank you, ma. Bye bye. See you. All the best.